Today, this is a topic outline for today. I want to start with MTA obturation. Then after that, I will do the demo for MTA obturation. And maybe in the afternoon, or maybe after the first topic, I want to talk about predictable and minimally invasive instrument retrieval. This is a very long topic, so it will take like 3 to 4 hours. So I keep talking about this for the rest of the day. So first topic, why MTA obturation over gutta-percha obturation in non-surgical retreatment? You know the reason. As I told you, I completely stopped using gutta-percha in 2010. And since 2010, I have been using MTA as a root filling material. So let me show you the success rate in endodontic therapies. So if you take a look, initial endodontic treatment, the success rate is very high if you don't see preoperative radiolucency from 88 to 97%. However, even if it's an initial endodontic treatment, if you see preoperative lesion, the success rate is much lower, 74 to 91%. But if you look at the retreatment, success rate with preoperative lesion is super low, significantly low, 61 to 84%. That is why I keep telling you it's important to use MTA as a root filling material. Why? Because I had higher success rate when I started using MTA. What about the surgery? Of course, you can do the surgery if the non-surgical retreatment fails. But look at the surgical success rate. Surgery without non-surgical retreatment will be very low, 44% to 78%. But the surgical success rate with non-surgical retreatment will be significantly higher, 84 to 95%. So it's very important to do the non-surgical retreatment first before the surgery. Don't jump to the surgery if the initial endodontic treatment failed. Very important. If you don't do this, your surgery will not be as successful as the surgery with non-surgical retreatment. So surgery should be done after non-surgical retreatment. You have to do non-surgical retreatment first in order to increase your surgical success rate. So this is a difference between the success rate of retreatment and the success rate of microsurgery. Actually, there is no significant difference between the two. However, if you look at the number, microendodontic surgery is a little bit better than non-surgical retreatment, maybe due to calcium silicate-based cement as a retrofill, because almost nobody, as far as I know, uses MTA as an ortho-grade root filling material. Everybody wants to use gutta-percha and sealer, maybe calcium silicate sealer. So why not you use MTA without gutta-percha? Maybe you can, of course, increase your success rate in non-surgical retreatment. So I have a question for you. What's wrong with gutta-percha and the sealer? If the root fillings with gutta-percha and the sealer is so successful and reliable, why don't you use it as a retrofilling material in periapical surgery? How many of you here use the gutta-percha and the sealer as a retrofill? Anybody? Do you use gutta-percha and the sealer as a retrofill? No, right? Nobody, right? Why you don't use gutta-percha and the sealer as a retrofill in surgery? Why don't want to use it? You know it doesn't provide good seal, right? That's why you don't use it. Then why you want to use gutta-percha and the sealer in non-surgical retreatment? It doesn't make sense. So that's why I keep telling you, why don't you use MTA, just MTA, no garapacha. So what is the goal of root canal treatment? You need to remove irritants from the root canal system, and you need to fill or obturate the clean and shaped root canal system. And you need to prevent future recontamination of the sealed root canals. These are the goals of root canal treatment. So if you want to reach the goals, you need to use the material that provides a good seal. That is MTA, not garapacha, because garapacha does not bond to dentin. Why you have to use the material that does not bond to dentin in order to have a good seal? So that is the answer. So let's compare the two preparation techniques for MTA obturation and for garapacha fillings. First, let's look at the garapacha fillings. I mean the preparation for garapacha fillings. You need to taper the canals because of the vertical condensations. So you need to use the instrument with a greater taper. 6%, 8%, sometimes 8%. 4% is not good enough. So everybody wants to use the instrument with a 6% or 8%. And the working length must be very accurate. Otherwise, you could overfill the canal or you could underfill the canal. So you have to be accurate. And you need more instrumentation time because you need to use many instruments to taper the canal. And that's why you have more incidence of ledge formation and more incidence for instrument separation. And sometimes because of you need to remove more dentin from the pericervical area, that's why you could result in vertical root fracture. And you could have more dentin sacrifice and more aggressive. But if you look at the preparation for MTA fillings, you don't have to be accurate in working length measurements. And you don't need instrument with a big taper. And you can just use several instruments to finish the preparation for MTA obturations. That's why you could have less incidence of ledge formation and you could have less incidence of instrument separation. And of course, the preparation time will be less than the preparation time for garapacha root fillings. And you can be minimally invasive. So there are many, many advantages if you prepare the canal for MTA obturations. So let's compare the properties between MTA and garapacha. So if you look at the properties of garapacha, you know, garapacha always have shrinkage, setting shrinkage, 7%. And if you obturate the canal with garapacha and the sealer, you need to depend on the coronal restoration. The prognosis of the tooth with garapacha and the sealer fillings depends on the coronal restoration. I don't want to depend on the coronal restoration. I want to have good seal in the root canal. And the tooth is susceptible to bacterial ingress because, you see the biofilms all the time on garapacha fillings and even sealer, like AH plus or whatever you have. And also, the tooth will be vulnerable. There's no ability to reinforce the tooth. So, it's not good to use garapacha as a filling material. But if you look at the properties of MTA, MTA has setting expansion. It will expand about 1% from 0.1% to 1%. So if it expands, there's no gap created between dentin and MTA. And MTA always forms interfacial layer between MTA and the dentin. That is sorry, I forgot the name of the material. the material between the MT and denting. I forgot, really forgot. Not sealer. No, not that one. Yeah, hydroxyapatite. Hydroxyapatite. Yeah. So you could have hydroxyapatite between MTA and dentin. That's why you have a good seal. And of course, you can increase fracture resistance over time. And as you know, MTA is highly biocompatible. So that's why even if you extrude MTA into the periapical tissues, nothing happens. No inflammations. And MTA is bactericidal. It kills bacteria. And also, MTA promotes cementogenesis, osteogenesis, angiogenesis, and PDL reformations. It's very friendly to the tissues. And it sustains alkaline pH for a longer period, maybe almost 10 months. And it has good bonding strength because it bonds to dentin. And it's difficult to remove, but that's okay. If something is difficult to remove, that means you have good seal. But garbature is easy to remove. That's why it doesn't bond to dentin. So there are many, many advantages over garbature fillings. So why do you still want to use garbature? Because it's easy to remove. I don't want to do another retreatment after obturating the canal with MTA because it's very difficult to remove set MTA. But if it didn't set, it's easy to remove, as I showed you yesterday. So let's look at the success rate between 1950 and 2000. So success rate between 1950 and 2000 was 74% under the strict criteria, 85% under the loose criteria. But if you look at the success rate between 2003 and 2020, look, it's very, very higher. 82% under the strict criteria, 92% under loose criteria, because of MTA becoming available in 1998, at least in the United States, and also in Japan, it became available in 2002. So I think this is a reason why the success rate after 2003 was higher than the success rate between 1950 and 2000. Because people started using MTA as a retrofill. But only a few people use MTA as an ortho-grade filling material. So the key to success in non-surgical retreatment starts with complete removal of garbature root fillings harboring bacteria. Because as I kept telling you the same story, if you use garbature and the sealer in retreatment, bacteria just love it because they want to form biofilms on garbature fillings. So that's why it's not a good idea to use garbature and the sealer in retreatment. So let's look at this case. Whenever I have a failure, I always find garbature fillings remaining in the root canal when I do the surgery. So this is pre-op, and this is 3 months post-op. Of course, I filled with MTA, but this is 7 years follow-up. Look at the lesion, the apical lesion. The apical lesion was getting bigger and bigger. So I had to do the surgery. So I did the root end surgery. And this is the root end resected from this tooth. And you can see garbature remaining in the canal. I couldn't remove all the garbatures in non-surgical retreatment. And this was the reason, because I didn't see anything else but. So this could be, I think, the reason why I had emerging periapical periodontitis here. And this is MTA. and this is garapacha remaining. After that, I completely removed the remaining garapacha fillings in the canal. And of course, I filled the canal with MTA. And this is patty, BC patty, and this is 6 months post-op showing nice periapical healing. Look at this. And another case, I had been using garapacha in the sealer until 2009, and whenever I saw a lateral canal, you see a lateral canal on the CBCT. This is a sagittal view. And you see the lateral region associated with the lateral canal. And I use continuous wave of condensation technique. I compacted garapacha and the sealer, and this is the immediate post-op. You see the garapacha and the sealer filled in the lateral canal. When I saw this, I was so happy. Oh my God, it's like I'm winning the game. Good. But I waited 3 months, 6 months, nothing changed. Look at the lesion size. It was the same. Nothing changed. Actually, it's a little bit bigger. But, the apical lesion was completely gone. But the lateral lesion was a little bit bigger. So I decided to the surgery. So this is garapacha and the sealer filled in the lateral canal. I took it out. Then I replaced it with MTA. So let me show you what I did here. So this is garapacha and the sealer, as you can see, obviously garapacha, not just a sealer. So I'm using orthosonics to remove garapacha. So this is how I use the orthosonics. So let me skip the middle part because this is boring. So it's clean. Nothing in the lateral canal. Then I placed MTA like this one. I use gray MTA, polluted MTA. And this is 1 month post-op, and this is 1 year post-op, showing nice lateral healing. You see the lamina dura completely reformed. Look here. And of course, the patient became asymptomatic. And look at this case. This is very similar to the previous case I showed you. So I found the lateral canal. Look, with a lateral region, like this. But I had already used MTA because since 2010, I have been using MTA as a root filling material. So I didn't, pay attention to this little lateral canal. It was only 1 millimeter, very short, only 1 millimeter lateral canal. So I didn't care about that because, you could underfill the canal. 1 millimeter shorter, 1 millimeter shorter than the apical foramen. That doesn't make a big difference. So this was 1 millimeter. So you could be 1 millimeter short. And I didn't, instrument the lateral canal. But I filled the root with MTA. So you see the lateral canal here facing distally, like this. I waited 3 months, 6 months, but look at the lesion size. Again, the lesion size was twice as big as the original lesion size after 6 months. So I had to do something, something more to solve the problem. So this left me 2 choices. One is to go back and locate the lateral canal and clean it and fill the canal with MTA. The second choice is to do the intentional tooth replantation, right? Because it's impossible to do the apical surgery because you see the lateral canal in the middle 1/3, not in the apical 1/3. It's impossible to do the root end surgery. And on top of that, you see the lateral canal facing distally. So it's very difficult to reach the lateral canal. So what would you do if you are in this position? Surgery, raise your hand. Intentional tooth replantation, raise your hand. Okay. Who wants to go back? Who wants to go back and clean the lateral canal? Nobody? Okay, only one or two. Okay. I went back because it's not difficult. It's in the middle 1/3. So I removed set MTA. As I told you, it could be difficult, but whenever you see the lesion, MTA usually does not set in an asset environment. So I went back, look, I located the entrance to the lateral canal. This is the lateral canal. So let me show you the video here. This is how I located the lateral canal, how I cleaned the lateral canal. Of course, I took another CBCT. I located lateral canal, untreated lateral canal. So I use the TFRKS, the small one. I pre-carved it, and I look for the sticky feeling. You know, every time you get into the canal, you feel sticky on withdrawal. So I activate ultrasonics only on withdrawal. Because it's only 1 millimeter. You can easily clean the lateral canal. Activate ultrasonics only on withdrawal. Then after that, I started filling the lateral canal with MTA. And this is what I got. You see the lateral canal filled with MTA. Only 1 millimeter. It doesn't matter if you push it out. If you extrude MTA into the periapical tissues, it doesn't matter. MTA is biocompatible. So it's very good. You don't care about the length. You just push it out. But don't be underfilled. You need to push it out. Okay? And this is 6 months after filling the lateral canal with MTA. And this is 15 months after the initial treatment. And look at the healing. And this is 18 months after the initial retreatment. And this is 36 months after the initial retreatment. You see nice periapical healing as compared to this one. So 1 millimeter lateral canal made a big difference. So don't ignore the small anatomical spaces if you see preoperative lesion. Biofilms are in there. Whenever you see preoperative lesion, something is there. So you need to clean it. Otherwise, the case would be fading. So why MTA obturation in non-surgical retreatment prior to microendodontic surgery? As I told you, your success rate will be lower if you don't do non-surgical retreatment first, prior to surgery. So I showed you this slide yesterday. So in 2009, I had only 123 surgical cases out of 1,478 cases, which makes 8.3% of all the cases. But in 2023, I had only 33 surgical cases out of 1,324 cases, which makes 2.5% of all the cases. So surgical cases dropped from 8.3% to 2.5%. Okay? So if you use MTA as an ortho-grade filling material, you could reduce the surgical cases. You don't need surgery if you use MTA. So are there any drawbacks to MTA obturation? Yes, of course. You have to understand the shortcomings of MTA obturation. Of course, MTA provides an excellent seal, but MTA cannot be guaranteed an asset environment. MTA will not set. So this means whenever you see the pus coming out, then you should not fill the canal with MTA. You need to see the pus, you need to see the pus not coming from the periapical tissues. And also the teeth stored in low pH after being retrofilled with MTA showed lower resistance to leakage than teeth stored in high pH. So this shows also MTA does not set in an acid environment. What about the thickness? The thickness of root filling material affects the ability of MTA. You need to have at least 4 millimeter thickness to have a good seal. It's not enough if it's 2 millimeters, 3 millimeters. That's why it's better to fill the root canal with MTA prior to surgery. So if you remember the case I showed you, the case with the lateral canal, I filled the lateral canal with MTA, but it was only 1 millimeter long. But the rest of the space was also filled with MTA. Somebody, I saw somebody, actually many people, use MTA, but they just put MTA maybe in the apical 3 millimeter, 4 millimeters. The rest, they want to use still garapacha in the sealer. It doesn't make sense. You need to fill the entire canal with MTA to have a better seal. So don't use just MTA for the apical 1/3. You need to use MTA from the root end to the coronal end. So advantage of MTA, non-surgical obturation prior to endodontic microsurgery are these. I don't have to read these, but especially MTA obturation in initial treatment can provide remarkable outcomes without the need of endodontic microsurgery related post-treatment morbidity. And osteotomy size can be more conservative. You can be minimally invasive in surgery if you have to do that. And the time for endodontic microsurgery can be shortened because all you have to do is just resect root end with apical bifurcations or something in the apical 1/3. Longer ortho-grade MTA fillings prevent more coronal leakage and inhibit more bacteria growth compared to the shorter retro MTA fillings. So that's why you need to fill the entire canal with MTA. Don't use garapacha. I know many people just fill the apical 1/3 with MTA, and the rest will be filled with garapacha in the sealer. That's not good. That's actually terrible if you do that. So how does MTA obturation improve non-surgical retreatment? Always mix MTA with PBS, phosphate buffered saline, because there are a few studies coming from South Korea, especially the Professor Yu. He did many studies on PBS and MTA. And the conclusion was MTA obturation mixed with PBS promoted crystallization and bacteria entombment, leading to elimination of bacteria in the canal. So this is SEMs. Look at bacteria in the dentinal tubules. You see many bacteria here in the dentinal tubules. You see the cocci, rod, and these. So if you fill the canal with MTA, they will be crystallized. So you can eliminate bacteria in the dentinal tubules if you mix MTA with PBS. Then what about the smear layer? Do you need to remove smear layer or you can keep it? What do you think? According to this study here, you don't need to remove smear layer. So this is the result. So this is the gray one represent MTA with smear layer. The black one represent MTA without smear layer. So as you can see, MTA with smear layer provided better seal compared to the MTA without smear layer. So you can keep, of course, smear layer. Of course, you can remove smear layer, but it's better to keep smear layer. That's why when I obturate canal with MTA, I intentionally scratch the root canal walls to create smear layer. Look at the comparison. You see the smear layers. If you fill the canal with MTA, and you have an excellent seal. There's no gap between MTA and dentin. This is dentin and this is MTA. This is five years after obturation. And this is 7 years. And this is 8 years after MTA obturation. No gap. You see the chemical bond. Actually, there's no gap between the two. Look at dentinal tubules. They are all crystallized. This is what you get if you mix MTA with PBS. And as I told you, MTA is highly biocompatible. So if you incubate osteoblast on amalgam, IRM, and MTA, look at osteoblasts. They died on amalgam, and they died on IRM, but look at osteoblasts. They are smiling on MTA. They are proliferating on MTA. Look at them. Do you see them smiling? So that's why, you need to use something biocompatible as a filling material. So which MTA is better in terms of promoting osteoblastic activities? So Proluto MTA, the original one, was the best in promoting osteoblastic cells. So look at this. So they used Proluto MTA, biodentin, and the sequence first setting, but MTA won the gold medal. So here, but when it comes to vital pulp therapy, MTA was the worst. And the sequence won the gold medal. So I want to use MTA when I obturate the root canal, but I want to use biodentin or endosequence when I do vital pulp therapy. So this is the difference. You need to choose which material is good. You need to understand the MTA should not be used in vital pulp therapy. You need to understand you have to use MTA, the Proluto MTA when you obturate the canal. And also, when the patient comes to your office in pain, it's better to do one visit treatment because MTA or in other words, calcium silicate-based cement exhibit anti-inflammatory effect. So MTA is always anti-inflammatory. So you can reduce the pain and also you can increase the pain threshold. And this is a very good study from George Bogan in Australia. He was an American endodontist practicing in Los Angeles, but he moved to Brisbane, Australia. And what they found was, when you obturate the canal with MTA, you see dentinal tubules completely calcified. This is MTA, and you see the green area showing crystallization in the dentinal tubules. So this is what they found. So penetration depth of pro-root MTA into dentinal tubules is not affected by smear layer removal, and MTA used as a root filling material can penetrate up to 90% of dentinal tubules. And the mean penetration depths were greater buccolingually compared to mesiodistally, because you remember the butterfly effect. You know the hardness. You see the more hardness of dentin in the mesio to distal direction as compared to the hardness in a buccal to lingual direction. So that's why you have more penetration depth buccolingually compared to mesiodistally. And MTA intratubular penetration depth varied from 352 microns to 1,821 microns, and it can be extended to the root surface. So this is good. MTA can take care of all the bacteria surviving the retreatment in the dentinal tubules. So you can eliminate those bacteria in the dentinal tubules. So it's very nice. Even if you extrude MTA, cementum will form on MTA. This is MTA. You see the cementum forming on MTA. So it's okay. MTA is biocompatible. If you extruded MTA into the periapical tissues, you will have hard tissue formed on MTA. And according to this study from here, Serifogel, and he showed apical level of root fillings after root canal retreatment with short root fillings was associated with significantly more post-operative endodontic disease. So you need to overfill the canal. Okay? It's better when it comes to the retreatment. Don't be underfilled, especially in retreatment. Initial endodontic treatment, you can be underfilled, but in retreatment, you should be overfilled because you can have better success. And this is my study published from JOE 2023, 2 years ago. And what I found from my study was healing was delayed close to 3-fold in the MTA underfilling group compared to the MTA flush filling and overfilling groups. So underfilling group showed the lowest healing rate, requiring surgical intervention in the majority of cases at 6 months. So again, I keep telling you the same story. If you do the retreatment, you need to use MTA and you need to overfill the canal. Don't underfill the canal. If it's an initial endodontic treatment, it's okay. But whenever you see the preoperative lesion, you have to push it out. So this is the blue line represents underfilling group. The red line represents overfilling groups. The green line represents flush filling group. So you can reach the goal 100% earlier with overfilling than flush fillings. But you never reach 100% goal with underfilling. So it's much, much better to use overfillings with MTA. So these are the results. If you overfill the canal, your success rate is 91%. I'm talking about the cases with the preoperative lesion 3 millimeters in diameter, more than 3 millimeters in diameters. I'm not talking about the retreatment without preoperative lesion. Every case I used in this study had a lesion size more than 3 millimeters in diameters. So whenever you see the lesion, you need to overfill the root canal, 91%. And if you do the flush filling, your success rate was 87%. If you do the underfilling, your success rate is below 20% whenever you see operative lesion. So this shows it's important to extrude MTA whenever you see preoperative lesions. So the retreatment outcomes of different MTA obturation levels in this study suggest the healing rate may improve using unmodified MTA, pure MTA, in cases where the level of fillings is flush or beyond the major apical foramen. MTA underfillings increases the chances for non-healing and surgical intervention. So extrusion MTA does not adversely influence the outcomes of non-surgical retreatment, and indication for surgical treatment increase after retreatment when MTA obturation cannot reach the apical foramen. So it's very important. It's crucial to reach the apical foramen with MTA when you do the non-surgical retreatment with preoperative lesion. Many people ask me the same question. Is it okay to use MTA sealer or calcium silicate-based sealer? The answer is no. Because look at this study. It's coming from Cairo University in Egypt. So it's going to be published, I think, this year. But I know the conclusion. So they use AH plus, BC sealer, or just MTA Angelus. This is not sealer. They fill the canal with AH plus and BC sealer and MTA Angelus. But MTA Angelus, pure MTA, obturation group showed the highest dentinotubular penetration depth compared to BC sealer and AH plus. Look at them. So this is MTA. You see, this is the depth of penetration, dentinotubular penetration depth, 1,011 microns. But look at the BC sealer. You see, you can reach only 384 microns. But if you use AH plus, you can reach only 108 microns. There are significant differences between the three. So it's not good to use a single cone technique with a BC sealer. You cannot eliminate bacteria from the dentinotubules. But if you use just MTA without gut aperture fillings, you can reach almost the root surface in the dentinotubules. And you can, as you know, eliminate biofilms, or you can at least reduce the biofilms if you use MTA as a filling material. But which MTA is good, better in terms of elimination or reduction of biofilms? They use three kinds of MTA. Gray MTA, the original gray MTA, and the original white MTA, pro-root MTA. They use endosequence root repair material. This is premixed MTA. You can see the highest reduction rate for the initial 3 to 24 hours if you use endosequence root repair material. However, if you look at gray MTA, white MTA mixed with water, you see the lowest reduction, biofilm reduction rate for the initial 3 to 24 hours. But as the time goes, you see the increase in in the biofilm reduction rate if you use gray MTA or white MTA. So it's better to use powder and water, powder MTA, as compared to premixed MTA. You lose the ability to reduce biofilms if you use premixed MTA. So I really want to mix MTA powder with PBS. Then I can keep killing the biofilms. I can keep reducing the biofilms over time. So this is the reason. As I told you yesterday, the incidence of external apical root resorption was associated with apical periodontitis. So this means whenever you see preoperative lesion, you can have external apical root resorption in about 80% of the cases. So this is, again, Rikuchi's study. He did retreatment because of the apical radiolucency. 17 years after the retreatment, the lesion was almost gone. But 19 years after the retreatment, you see the lesion coming back. This is emerging apical periodontitis. So whenever you see the lesion, he did root end surgery, and this is the root end dissected from this tooth, and he found external root resorption. Whenever you see the external root resorption, you have biofilms. So actually, he found this is gut aperture, and this is biofilms. And this is biofilms, and this is gut aperture. So you always see biofilms on gut aperture and in the external root resorption. So whenever you see the preoperative lesion, you have biofilms, and you have external root resorption, and you have like this. So how do you treat this kind of case? If I see preoperative lesion, I want to extrude MTA, covering the external root resorption area, then you can eliminate the biofilms. So this is my protocol. Whenever I see preoperative lesion, I push MTA into these small spaces. So that's why whenever I see the external root resorption like this, it's difficult. Because in this case, I was not able to get MTA into the external root resorption area, so I did surgery because there was lateral canal, but I was not able to reach the lateral canal. So what I did in this case was I covered the external root resorption area with MTA. So this is the lateral canal. I was not able to reach the lateral canal in non-surgical retreatment. But in surgery, I was able to reach the lateral canal. I filled not only the lateral canal, but also the external root resorption with MTA. So I filled the external root resorption with MTA. This is MTA. And this is MTA covering the external root resorption. And this is the lateral canal filled with MTA. I waited 6 months, and you see the nice periapical healing. So this is what I do every day. I want to get MTA into the external root resorption non-surgically. But if I didn't, I do the surgery and do the same. In this case, you see external root resorption here and here, and between the two roots. Then I was not able to get MTA into the external root resorption. And also, I found calculi between the two roots. So this case involved perio problems. So I did intentional tooth replantations. So I removed calculi from the two roots, and I put MTA in the external root resorption together with the spaces with MTA between the two roots. So this is 6 months post-op. You see the MTA filled between the two roots. Another case, this case was very good for me. You see the big region between the two roots. Actually, you see big region, and you see the external root. Look here, external root resorption. This is the apical foramen. This is apical foramen. And you see the external root resorption. Look here. I was able to get MTA into the external root resorption. I really pushed it. I didn't apply lots of pressure because I don't want to, because I just wanted MTA to get into the external root resorption. So I didn't, I just used sonics, not ultrasonics. With sonics, you can get MTA into the external root resorption area. So I was successful covering external root resorption with MTA. And anyway, this is 10 months post-op showing. So this is MTA in the external root resorption. Here, this is before the retreatment. This is 10 months after the retreatment. Look at the MTA covering the external root resorption, like this. And this is 48 months post-op showing the same. Looks good. Of course, the patient is asymptomatic. And this is another study published from JOE 2021. Here, you see Falco region, and you see big apical region elevating the sinus floor. But I found, very, very little vital tissues in the palatal root. So whenever I find vital tissues surviving the initial treatment, I always want to save the pulp tissues. So I did revascularization procedure only for the palatal root. So I induced bleeding, and I placed collagen fiber over the blood clot. I placed MTA over the collagen fiber. Then I filled the buccal root canals with MTA. I waited 6 months, 1 year. Look at the healing. Look at the healing. You see big defect between the root. You see the nice bone formed between the roots. And you see the bone level actually increased here. From here to here. So you can do that. Whenever you see vital tissues, you can always do the revascularization procedure. This is another case. The patient was 33-year-old female. You look at the big lesion. Look here. You see the lesion elevating the sinus floor again. But this patient didn't want me to remove the pulp tissues. And I found vital pulp tissues here. This is the vital pulp tissues. Because I didn't anesthetize the patient in this case. Because I told the patient, if I anesthetize you, you don't feel anything. So how can I find the vital tissues? So you need to tell me if it hurts. I want to make sure if I see the vital tissues. So let me show you what I did in this case. Sorry. Okay, excuse me. So this is, I'm doing this without anesthetizing the patient because I wanted to know if the vital tissue is still surviving. Sorry, I'm feeling the canal. Sorry. Let me go back. Actually, this is not what I wanted to show you. Sorry. Okay. Let me go back. So anyway, I was supposed to show you the vital tissues. When I touch the tissue, this tissue, the patient said, "Oh, you're hurting me." But I'm sorry, she will speak in Japanese. But when I touched this tissue, she said, "You're hurting me." Then, oh, okay, this is vital. I found a vital tissue. So then I started doing the revascularization procedure. I waited until I had blood clot. Then over the blood clot, I pressed Coracoat. Then I pressed MTA over the Coracoat. Then I waited 1 month, and this is immediate post-op. You see the lesion. And this is 3 months post-op showing nice periapical healing. You can still see small lesion, but it's getting much, much better. And the tooth remained vital. So whenever you see vital tissues, I always do revascularization procedure to increase the vital tissues. So in retreatment, you need to remove gut fractures and you need to remove broken instrument if you have any, and you need to clean the isthmus or small anatomical spaces, lateral canal, the apical bifurcations. And you can use irrigation device that you like, ultrasonics or laser, whatever you have. Then you can clean the small anatomical spaces, but you could have external root resorption. In that case, you need to overfill the canal. You need to extrude MTA into the external root resorption, like this. Then you see the healing. How do you do that? I always use the device called H12MT. As I showed you this yesterday, everything is controlled by the foot pedal. If you push the brake pedal, you can activate the rotations. I use T mode plus. This is not T mode. This is T mode plus. With the T mode plus, you can control 3 different motions. The first motion I want to use is 90-degree watch winding. I want to keep using 90-degree watch winding until I reach the apex. As soon as I reach the apex, I want to use the second motion, that is counterclockwise rotation, maybe around 100 RPM. Then, because this motor, 812MT, has a built-in apex locator, or you can be connected to an apex locator. So you have choices. So as soon as you see the reading going from the apex to 0.5, then I will activate sonics to further condense MTA and remove voids from MTA. Because whenever you condense something, you have voids, no matter if you use garapacha or sealer or MTA. So then you keep looking at the apex locator. When the reading goes from apex to 0.5, you see you need to activate ultrasonics. You need to activate sonics, not ultrasonics. Sorry. Then you keep looking at the apex locator. You see immediately go back to the apex. Then you will use sonics and you will use the counterclockwise rotation and you will use a small up and down motion. Then the reading goes again from apex to 0.5. Then that means you are finished with MTA obturation in the apical 1/3. After that, I just take out the plagas. They are all multisynthetic phase. So you can pre-curve the plaga and you can go around the curve and you can finish MTA obturation in the middle 1/3 and maybe in the corner 1/3 if you are not planning to place a post. So if you want to activate sonics, you just have to push the red button. If you want to change the intensity of sonics, you can just push the yellow button. There are 3 different intensities: low, medium, and high. I always use high. So for example, if you have external root resorption, I want to use higher sonic activations. But if you don't have, if you don't have, an open apex, or if you don't have, if you have small apices, then you don't need higher power. You just need lower power. So these are the pluggers made of multensthetic nickel titanium. So this is how you obturate canal. First, instrument the canal with whatever instrument you have. Then take out the instrument, one size, maybe 2 sizes smaller than the final preparation size. For example, if you went from maybe 5004 up to 4004, then you need 3504 or maybe 3004, depending on the width of the canal. So you need to use the instrument that can go to the apex without resistance. Any instrument going to the apex without resistance can be used. So I will pick up the instrument, usually one size smaller than the final preparation size. Then mix MTA with PBS, take it into the root canal, and start using 90-degree watch winding, and push MTA to the apex. When you reach the apex, you will start using counterclockwise rotation. You just have to push the black button. Then you are using counterclockwise rotation. Then you see the reading going from the apex to 0.5. Then you will activate sonics to remove voice and further condense MTA. And you will see the reading going from the apex to 0.5. So that means you are finished with MTA obturation in the apical 1/3. If you want to obturate the canal with MTA in the middle 1/3 and the corner 1/3, you just need to use the pluggers that I showed you. This is how you obturate the canal. So let me show you the animation to just give you an idea how you obturate the canal with MTA. So I use 812 MT. So something like this. So this is watch winding. Whenever you reach the apex, then you need to use counterclockwise rotation at 100 RPM usually. Then you start condensing MTA into the apical direction. Whenever you see the reading 0.5, showing 0.5, you need to activate sonics. Then you can remove voice and you can further condense MTA. You can get MTA into small anatomical spaces such as an isthmus or the lateral canal. So with sonics, you can remove voice like this. These sonics activations. All you have to do is just push the black button. Then when you see the reading 0.5, you are done with the MTA obturation in the apical 1/3. So this is how you proceed to MTA obturation. First, you need to instrument the canal. You need to irrigate the canal, and you are ready to obturate the canal. So this is staining in the lateral canal and the main canal. First, you need to prepare the canal. This is S1. I'm using T mode, 90-degree watch winding, and the reciprocating motions after passing the greatest curve, the midpoint of the curve. 380 degrees clockwise, 50 degrees counterclockwise. Then I go to the next one, S2. I will go from S1 to F3, the biggest one. 90-degree watch winding. After passing the midpoint, I want to use reciprocating motion. Of course, you can keep using 90-degree watch winding until you reach the apex. It's okay, but it takes time. But it's safer to keep using 90-degree watch winding. And this is the next one, F1. I'm using 90-degree watch winding. After passing the midpoint, I want to use the reciprocating motion. 380 degrees clockwise and 50 degrees counterclockwise at 150 RPM. Then this is F2. I do the same. I reach the apex. Then the final one is coming, F3. This is F3. I started with 90-degree watch winding. After passing the midpoint, I want to use the reciprocating motions. So as you can see, the staining was removed, except the lateral canal. So I want to use ultrasonic irrigation device to remove the staining from the lateral canal. This is a new prototype irrigation device. So you can remove staining from the lateral canal, like this. This product will be coming from woodpecker. Like this. Then you need to, before you obturate the canal, I always use XP finisher. So this is XP finisher, like this. Usually XP finisher expands more in a patient's mouth. But this is, I'm doing this in a room temperature, so that's why it doesn't expand very well. But anyway, with the XP finisher, you can touch all over. Then this is the final irrigation. Everything is clean except the orifice. And dry the canal. I do the demo after my lecture. So you can just irrigate canal and dry the canal. You don't have to completely dry the canal because you need moisture for MTA to set. Then here comes mixed MTA. You just use carrier and put it in the canal. Carrier has spoon, so you can just take it and put it in the canal. It's very simple. And you take out the instrument. This one is the instrument F1, 2 sizes smaller than the final preparation size. So I'm using 90-degree watch binding. Then as soon as I reach the apex, I use counterclockwise rotation. That's why MTA is being delivered into the apex. So I keep using counterclockwise rotations with a small up and down motion. As you can see, I keep using a small up and down motion, like this. Then you feel pushed from the apical 1/3. When the reading goes from the apex to 0.5, then you will start using sonics. So add more MTA, because I want to really condense MTA into the lateral canal. 90-degree watch winding, always start with 90-degree watch winding. Then clockwise rotation whenever you touch the apex. So you need to keep using counterclockwise rotation when the reading shows 0.5. Activate sonics. Then you can immediately get MTA into the lateral canal with sonics. So keep using a small up and down motions. Then you can really condense MTA with sonics. At the same time, you can remove voids. When the reading shows 0.5, you are finished with the MTA obturation in the epic 1/3. If you see voids after taking the post-operative radiograph, you can go back because the setting time of MTA is usually 3.5 hours. So you can easily remove MTA, but you need to hydrate MTA, you need to use sonics, and you need to use ultrasonics to get MTA out. So let me show you how you can do that. Whenever you see yourself underfilled, you need to go back and push it out. So this way, this is condensed MTA. I'm going to remove all the MTA. It's not set. So I'm using clockwise rotation with sonics. This is sonics with clockwise rotation. Because of sonics, you can reach the apex easily. So as you can see, MTA is being removed. Like this. Then irrigate the canal, of course, with water. And keep doing the same. Clockwise rotation with sonics. If you use counterclockwise rotation, you will condense MTA. So you need to use a reverse rotation, clockwise rotations with sonics. Now I have reached the apex. But look at the lateral canal. MTA in the lateral canal remains. Irrigated canal, you see the canal is empty now, except the lateral canal. Then you need to use ultrasonic irrigation device. Look, you are getting MTA out from the inside, like this. So this way, you can remove MTA from the root canal system. Now the MTA in the lateral canal is completely gone. So this is how you remove MTA. So let me show you how sonic activation affects the ability to remove voids. So as you can see, as soon as I started activating sonics, you see the voids. You see the voids here. Voids are coming out towards the coronal end, as well as a void in the lateral canal. So this is how you use sonics. So if you do that, I want to show you some cases from my practice. You see a big region. There's no border between the oral cavity and the sinus. Nothing. But I intentionally overfilled the canal with MTA. And this is 6 months post-op. Look at the bone. Completely deformed in the defect. Look here. Before the retreatment, there's no bone here. 6 months after the retreatment, you see the bone. Look here. And this is the broken instrument case. I remove the broken instrument, 3 minutes, then I fill the root canal with MTA. I intentionally extruded MTA. Every case, I try to extrude MTA. Then this is 3 months post-op. And this is 6 months post-op. Very nice periapical healing. You see a huge lesion. Look at the lesion size. It's huge. The lesion size is as big as the root. But it doesn't matter. If you just instrument canal, irrigate canal with ultrasonics, then you need to overfill the root canal. I intentionally extruded MTA. This is the extrusion of MTA. I waited 6 months. I took CBCT. The CBCT shows nice periapical healing compared to the pre-op lesion here. Of course, the patient is completely asymptomatic. Look at the big defect distal to the root. This is a second mandibular molar. You see something, hard tissue in the defect, but it doesn't matter. So what I did was I induced bleeding whenever you see a huge lesion like this. Small lesion, I don't induce bleeding, but if you see a lesion bigger than 10 millimeters in diameters, then after bleeding, I remove the blood from the canal and I intentionally overfill the canal with MTA. 1 month, this is 3 months, 5 months, showing nice periapical healing. And this is 72 months, showing the same. Look at something. Look at hard tissue. Around hard tissue, you see nice periapical healing in the defect. Look at the lesion here before the retreatment. Now you have complete bone reformation in the defect. Another case, you see the lesion like this, big lesion. I induced bleeding. However, I found vital tissues in the mesial root. So I always, whenever find the vital tissue, I always do the revascularization procedure. But for the distal roots, everything was necrotic. So I did revascularization procedure for the mesial root. And this is immediate post-op, this is immediate post-op, and this is 3 months post-op, and already showing nice periapical healing as compared to this. Look, of course the patient was already asymptomatic. Another case, you see a big lesion like this, you see the Farco lesion, but I found vital tissues in the mesial root. So I decided to do the revascularization procedure. And this is the mesial root, this is distal root. Distal root was completely necrotic. So I did revascularization procedure for the mesial root. This is 6 months, this is 24 months post-op, showing nice periapical healing as compared to the preoperative lesions. Of course, the patient is completely asymptomatic. Another case, you see the perforation here. Perforation, you see the big perforation. This is the original canal, and this is the perforation. Somebody considered the perforation the root, as a root, but it was not root. It was a perforation site. So I intentionally extruded MTA beyond the perforation site. Of course, I extruded MTA beyond the apical foramen. And this is 1 month, 3 months, 18 months, showing nice periapical healing. Look at the hard tissue in the defect as compared to these preoperative lesions. Look here. It's beautiful. And I think I showed you this. This is an extreme case. You see the external root resorption. Look at the external root resorption. A huge lesion. I always induce bleeding before I obturate the canal whenever I see a big lesion. I intentionally extruded MTA, but I was not able to cover the external root resorption. However, look at 18 months post-op. This is 18 months post-op. You see the hard tissue formation. Every case is different. I don't know why I had hard tissue formed on the external root resorption. But this is what I got 18 months after the MTA obturation. Before MTA obturation, you see the concavity, that is external root reduction, but 18 months after the MTA obturation, you see the hard tissue formation. The root shape is completely different. I saw something going on 6 months after the MTA obturation. Something going on. Another case, you see the sinus tract, and you see a big region. Sorry, big region, and big region around the root. And look, there was no crown. So I built up the composite crown bonded to dentin. It's not removable because the patient wanted to look nice. So I built the tooth. Before I started the retreatment, the patient had a terrible looking coronal restoration. So I created the composite crown. This tooth is temporary composite coronal restoration bonded to dentin. This tooth looks much better than this. So anyway, I extruded MTA into the periapical tissues. I waited 6 months, and you see healing, and I waited 24 months. Now you see complete periapical healing as compared to this. Look at the hard tissue covering the root. And this is also very interesting case. This patient was a lawyer, and he had 3 clients suing the dentist for malpractice. I mean, the dentist placed implant which failed. So the patient sued the dentist who placed an implant. So he didn't want to receive an implant. So that's why he was referred to me to do something about this. You see a big region. The root and surgery was already done, but look at the space here. Look at space. Somebody forgot to place retro fillings in the space. And also, the coronal restoration was bad. I saw the gap. So there are 2 reasons why this case failed. First, somebody didn't place the retro fillings, and the coronal restoration was not good. I saw the gap. So I decided to remove the post, remove the coronal restoration, and remove the post. It's easy if you have a microscope. It's easy to remove the metal post because the post is always straight. You just go down without touching the root canal. So I removed it without touching the root. So I removed the coronal restoration. I removed the metal post. Then what I did was, because look, the root to crown ratio was terrible. So I wanted the root to be longer. So that's why I intentionally extruded MTA. 2 millimeter, I extruded MTA 2 millimeter beyond the apical foramen. Do you know what happened? This is 1 year post-op. Look, the root is longer as compared to this. Besides, the root is longer. You see the nice periapical healing. Look at the lamina dura, completely reformed on MTA. And this is 3 year post-op, and this is 12 year post-op, and this is 17 year post-op. The tooth is still there. Patient was so happy. He referred actually 11 more patients to me because he had many friends. Okay, I'm almost done. So, if you do something good to your patient, you will have returns. And he was so happy, and the tooth is still there. So everybody can do this, okay? Maybe you are afraid of removing the post, but it's not difficult. If you have a microscope and you can go down between the post and the dentin, but try not to touch the dentin. I always create a space around 180 degrees, and I activate orthosonics. Then usually post will come out. This is how I remove the post, the metal post. I have thousands of cases with a longer post. Sometimes you see the post reaching the apex. Sorry, it's in Japanese. You have to go like this. First, if you have a deep post like this, what you have to do is create the space around 180 degrees. Then isolate the post, remove the blue area, and activate sonics from the buccal side and lingual side. Then you can remove the post. So if you do that, you can go like this. You create a space, you just try not to touch the dentinal walls, but you need to touch the metals. I use this kind of bars, carbide bar, very small one. Then I create semicircular space, 180 degrees. Then after that, you just remove the 1/3 of the post length. For example, if the post is 6 millimeters, I remove 3 millimeter space. So something like that, then you can remove the post. For example, if you have the post like this, look at the post. It's reaching the apex. I'm, when I see this, oh my God, someone was very good placing the post. You don't need garapacha fillings, but this case was failing. Look at the region. Sorry. Look at the region. Come on, wait, here. Look at the region here. But this post is actually touching the apical foramen. Wow. So I created the space about 1/3 of the broken file length. Not broken, sorry. The 1/3 of the post length. Then I applied orthosonics, the post came out. So you can stay minimally invasive. Sometimes, look at this case. The post is longer than the root. Look, this is the post. The post is longer than the root. Sometimes you could fracture the root. Fracture the post, sorry. Fracture the post. But you can just go down with a carbide bar without touching the root canal walls. Because I use small size round bar. And you can remove the post, the metal post, because metal post is always straight. There's no curved metal post. So if you do that, you can remove the post. So I'm so good at removing this kind of post.